When you examine a patient, one of the first things you do is to examine the pulse, but we also measure the pulse on our monitor in the ICU through the pulse oximeter and the arterial waveform. In this tutorial, we're going to look at that pulse, the waveform, the pulsatility index, and pulse pressure variability. An introduction to critical care with me, your host, Pat Nelligan. This is part of the Integrating and Interpreting Data in the ICU series. This is what you look at when you've already examined your patient and taken a history, and we've moved on to cardiovascular assessment. This tutorial is about the pulse. In the previous tutorial, we looked at the generation and control of heart rate, adrenoceptors and how they work, adrenoceptor agonists and antagonists, how alpha-2 receptor agonists work, and we looked at sinus bradycardia and sinus tachycardia. In this tutorial, I will discuss measurement of pulse, the perfusion index, and pulse pressure variability. The principal purpose of the heart is to receive and eject blood cyclically into two parallel circulations, one that runs through the lungs and one that runs through the systemic circulation. Regardless, the principal output of the right ventricle and the left ventricle is the stroke volume, and that is approximately 0.7 to 1 ml per kilo of ideal body weight, 50 to 100 mils. Once the stroke volume leaves the left ventricle, it passes through the aortic valve and along the artery and arterioles. And it does this as a waveform that is propelled by pressure generated by the left ventricle, and there is elastic recoil on the blood vessels. That pulsatile flow only goes as far as the capillaries, and then it dissipates into a lake of venous blood on the far side. The waveform is palpable as a pulse at various parts of the body where major arteries are superficially located: the carotid artery, the brachial artery, the radial and ulnar arteries, the femoral artery, the popliteal artery, the posterior tibial artery, and the dorsalis pedis. When we feel the pulse, we typically ask 4 questions. Is it palpable or not? This gives us an indication of the blood pressure and the cardiac output. Is it strong or weak? This gives us an idea about the stroke volume. What is the rate? This tells us whether the rate is normal or pathological, whether it is bradycardia or tachycardia. And what is the rhythm? Is it regular or irregular? The palpability is determined by the blood flow and the blood pressure. The volume is determined by stroke volume, in other words, circulating volume and venous return. The rate is determined by the autonomic nervous system and drugs that impact it. And the rhythm is determined by the presence or absence of arrhythmias and whether or not the patient has been treated for those arrhythmias. The heart rate itself is an electrical response that typically is evaluated on electrocardiography, usually lead 2, and that gives us excellent information about rate and rhythm, whether the heart rate is regular, irregular, fast or slow, and displays a variety of morphological appearances and dysrhythmias. But the pulse itself is electromechanical. It represents actual cardiac pumping activity. Not every complex results in a palpable pulse. So generally in medicine, we are more interested in the pulse rate rather than the heart rate. However, the monitor tends to default to the ECG as the pulse source rather than better pulse monitors, and this can be problematic due to electrical interference. For example, by the diathermy in the OR, patient movements, or ECG sensors falling off, and occasionally a very tall T wave results in double counting of the pulse. In the ICU, the pulse can be evaluated and measured accurately using one of the following approaches: palpation, as I've already mentioned, pulse oximetry, and arterial cannulation. This is an arterial line where a catheter is placed directly inside an artery and the waveform is transduced on the monitor. Most of the time we use the pulse oximeter to measure the pulse, and the machine delivers a waveform that is visible on the monitor. I'm a big fan of pulse oximeters, but over the years I have been tortured by them, particularly in the operating room. In the early days of pulse oximetry 30 or so years ago, the pulse oximeter signal became damp and then vanished for all kinds of reasons, having previously worked well. And in general, the way we were trained was that if the pulse oximetry tracing sort of disappeared, that indicated that the patient's blood flow, that's their blood pressure versus their cardiac output, had fallen. However, that is no longer the case because modern oximeters have tremendous capacity to amplify signal. And as a consequence of this, the manufacturers developed a thing called the perfusion index. And this is the way the pulse oximeter displays the difficulty of taking the pulse and putting a waveform on the screen. So it quantifies the quality of blood flow. It's the ratio of pulsatile to non-pulsatile, that's static blood flow, in the finger, the toe, or the ear. The perfusion index value may go from 0.2%, that's a very weak pulse, up to 20%, which is a very strong pulse. I have never seen a number more than 6 or 7. In fact, when I put this on my own finger coming out of the operating room last week, it was an orthopedic operating room, my number was less than 2. Now be aware that there are 2 different technologies for pulse oximetry incorporated into ICU monitors, those from Nellcor and those from Masimo, and they're a little bit different, but all the devices use the perfusion index. So as I mentioned, 0.2 to 1% are low values, and that represents poor perfusion, and I think this is useful. Anything from 1 to 5% are moderate values where the perfusion is okay, the flow is adequate, and then greater than 5% are high values, about which I don't know what to make. Virtually every patient I've ever looked at in the operating room, and most people don't even look at the perfusion index, those numbers are between 2 and 3, often in the ICU between 1 and 2. Where do you find this perfusion index? This is a photograph of a screen in a patient that I was looking after recently. Well, you can see there in the middle the waveform and the number 98. That's the oxyhemoglobin saturation. This is the pulse waveform. This is the pulse rate, 42. It's pretty slow. And the perfusion index, 2.49. So by looking at this, you can say, yes, the patient is oxygenating well, they're perfusing well, but their heart rate is just a little bit slow. This is a patient in the ICU on the same day, and this patient is doing poorly. There are very, very high pulmonary arterial pressures. That's the waveform on the top of the screen, and a very low perfusion index. Now on the Masimo pulse oximeter, they also have this technology known as Rainbow SET. It's a system where they measure a wide array of light wavelengths, and they measure the perfusion index, and they also have a thing called the Pulse Variability Index that works like Pulse Pressure Variability, about which I'll mention a little bit later on, and it has a nice cool looking waveform on the screen, and on this particular picture the Pulse Variability Index is 13%. If you don't have Masimo pulse oximeters, you don't have this. In our practice, most of the pulse oximeters are made by Nellcor. Once a year or so, I draw this picture. Again, it's in every textbook, and it matches the electrical activity of the heart with the mechanical activity of the heart. So you have the waveform for ECG, central venous pressure, the left ventricle, and the pressure in the aorta. But I'm going to squish this down to just these 2 waveforms, the ECG and the aortic pressure, and you can see them here. You can draw them out yourself. The aortic pressure waveform is amazingly useful, but we can't see it. What we see is a distal waveform, usually in the radial artery where we've placed a cannula. And this is what it looks like. It's less curvy and more spiky. And this is the traditional waveform that you will see on any arterial line, on any patient in the operating room of the ICU. And there is a wealth of information in this tracing. Firstly, you need to understand what the tracing is. There is an upstroke, that is the systolic upstroke, that's systole, and we have a peak pressure at the top of systole. So that's the systolic blood pressure, in this case about 125 millimeters of mercury. And then it drops off to another spot known as the dicrotic notch. That's traditionally being referred to as evidence of closure of the aortic valve, but it's a little bit more complex than that. In general, we recognize it as an incisura, a little blip in the waveform. Below that level, though, is the diastolic runoff that leads to the bottom, that is the diastolic pressure. So if we were to look at the area under the curve, this is systole, and then after the dicrotic notch, that is diastole. The difference between the systolic pressure and the diastolic pressure is the pulse pressure. That waveform on the outside can be looked at and evaluated in a variety of different cardiac output monitors using a thing called pulse contour analysis that gives us all kinds of information about the cardiac output, the stroke volume variability, etc. But for the rest of this tutorial, I'm going to look at pulse pressure variability. The pulse pressure is the difference between the systolic and diastolic blood pressures. The pressure in the arteries that reflect contraction versus relaxation of the heart. That pulse is the combination of the stroke volume and the compliance of the arteries. If the blood pressure is 120/70, the pulse pressure is 50. That pulse pressure varies with the respiratory cycle. That variability is different depending on whether the patient is breathing on their own or whether they're on positive pressure ventilation. In the majority of situations where we are interested in pulse pressure variability, the patient is on positive pressure. During inspiration, when the patient is being mechanically ventilated, blood pressure increases. It falls during the subsequent expiration. Positive intrathoracic pressure has multiple effects on both the right side and the left side of the heart. There is increased right ventricular afterload due to the increased pulmonary arterial resistance caused by the breath. There is reduced atrial filling on the right side due to impaired venous return. The right ventricular dimensions are reduced. Simultaneously, there is increased pulmonary venous return, resulting in increased left atrial and left ventricular filling, with increased left ventricular compliance due to reduced transmural pressure, reduced left ventricular afterload, and reduced ventricular interdependence, which means that the right ventricle is no longer bowing into the left ventricle because it's smaller. Thus, left ventricular stroke volume and associated pulse pressure increases during inspiration, but falls during the subsequent expiration. In the hypovolemic patient, the left ventricle is functioning on the steep part of the Frank-Starling curve. Consequently, small changes in preload associated with respiration induce large changes in stroke volume. If the patient is euvolemic, they're on the flat part of the Frank-Starling curve and their respiratory cycle has minimal impact on stroke volume. Let's illustrate this. We're starting with the patient at end expiration. The patient is intubated, so we're going to deliver a tidal volume and the lungs will expand. So now the patient is at end inspiration. I'm now going to replace the anatomical heart with a model featuring the right side of the heart and the left side of the heart. In between is the pulmonary circulation, and these connect to the systemic circulation. This is to keep things simple. Let's look at inspiration. Once inspiration takes place, using positive pressure ventilation, venous return reduces. The right side of the heart becomes smaller, so the right ventricular end diastolic volume reduces. This allows the left ventricular dimensions to increase. Positive pressure inside the chest pushes venous blood into the left side of the heart. There is increased left ventricular preload and reduced left ventricular afterload. This results in an increase in the left ventricular stroke volume and an increase in the blood pressure. Then we move to expiration. Once elastic recoil happens and expiration takes place, and the size of the thorax reduces and the pressure within the thorax reduces. There is an increase in venous return. This increases right ventricular end diastolic volume. There is reduced emptying of the pulmonary veins. There is reduced left ventricular end diastolic volume, resulting in reduced left ventricular stroke volume and reduced blood pressure. This variability in the pulse pressure between inspiration and expiration in the mechanically ventilated patient is unbelievably useful in clinical practice. Often it's very difficult to see pulse pressure variability on the screen because the speed of the arterial waveform is set at 25 millimeters per second, and the end-tidal CO2, which represents ventilation, that waveform runs at 6.25 millimeters per second. So in this example, I'm changing the waveform speed. You can do this on your monitor. So the waveform for the pulse and for the end-tidal are exactly the same. Remember that the trough on the end-tidal CO2 waveform represents inspiration and the peak represents expiration. Now let's see what happens with a patient. You can see that there is a roller coaster-like picture on the arterial waveform. On inspiration, the pressure goes up and then it drops down during expiration, then it goes up and then it goes down. Now we can apply a cursor to this, looking at inspiration and expiration and looking at the different pulse pressures, and then we can calculate out the pulse pressure variability. And for many years, that's what we did in the operating room when pulse pressure variability became something of interest. But these days, the majority of intensive care monitors, the modern ones, and the majority of anesthesia monitors will calculate out pulse pressure variability for you. And it will generate a number. And that number is important. Normally, pulse pressure variability is lower than 10%. Usually it's about 5%. If the fall in the pulse pressure is more than 13%, this is a very sensitive indicator of fluid responsiveness. It doesn't mean that you have to give the patient fluid, but it means that the patient will respond to fluid by increasing their stroke volume. I will discuss this in more detail in the tutorial on hemodynamic monitoring. For now, let's review this tutorial. In this tutorial, we looked at measurement of pulse, we looked at the perfusion index. That number, less than 1, suggests poor perfusion. Anything over 1, in my opinion, shows that the patient is well perfused. And then I moved on to talk about a very important topic, pulse pressure variability. In the next tutorial, we're going to move on and talk about blood pressure. Firstly, what blood pressure means, how it's measured using oscillometry or intra-arterial catheterization, and then we'll look at drugs that increase and decrease the blood pressure. I'll see you then, and I guarantee you'll learn something. So that was the pulse. Next time we're going to look at the blood pressure, how it's measured and what we do to change the blood pressure when it's high and when it's low. If you're enjoying the tutorials, please subscribe. Follow me at CCM Tutorials, also on my blog ccmtutorials.org. I'll see you soon.